Thank you for joining iMeet. This meeting is now being recorded.
Good evening, everyone. I'm Ara Christian coming to you from Loma Linda University, and on behalf of my co-moderator, Dr. David Shaw from Harvard UCLA, we're excited to welcome you to another highly anticipated edition of our AABIP webinar series. Today we have a very popular and exciting topic. But before the formal introduction, I'd like to review a few housekeeping matters. First, everyone, please note that this webinar will be recorded. It, along with previous and future webinars, can be viewed on the AABIP website and can be found under the Education and Training tab on the front page. Second, we ask that all participants mute their phones during the course of the webinar to minimize the background noise and to optimize the overall listening experience for everyone. Alternatively, you can use the volume control icon at the bottom right of your iMeet window. To ask questions or communicate with the group during the webinar, please type them into the chat box. This can be accessed by clicking on the thought bubble icon located in the bottom left of the iMeet window. We will keep track of the questions as they come up and give the audience ample opportunity to address, to ask the questions and to also address the questions toward the end of the hour in a formal Q&A period. So please feel free to type in your questions at any time. Also on the bottom left is a projector icon. This allows the audience to toggle between the presenter's slides and any videos that may be as part of the talk. And finally, a couple important disclaimers. The AABIP does not endorse any specific technologies or products. Also, the content and views expressed within the webinar represent the opinions of the speaker and do not necessarily reflect those of the AABIP. So without further delay, I'd like to turn things over to Dr. Shaw for our formal introductions today.
Great, thank you, Ara. Today we are very fortunate to have Dr. Momen Wahidi join us to talk about coding and billing in bronchoscopy. Dr. Wahidi is the Director of Interventional Pulmonology and Bronchoscopy at Duke University Medical Center. And for anyone who also does not know Dr. Wahidi, he is the ex-president or president ex officio of the AABIP, where he has done, just finished a tremendous 2-year term and now has a deserved rest. So I really appreciate Dr. Wahidi taking the time to join us for today's talk. Dr. Wahidi, the floor is yours.
Thank you, David and Ara. I appreciate the opportunity today to talk about this important topic. And I want to start by saying that I don't have any disclosures related to this talk. I want to make sure that you know that billing practices vary per state, carrier, and institution. So some of the things that we discussed today might be different for where you practice, but the principles are all the same. So always check with your revenue or business manager to validate some of the things we discussed today, how they apply in your state. And again, in this talk, we talk about some dollar amounts, some reimbursement amounts. Those are approximate. Those are mainly Medicare per state. They're different from state to state, from year to year. So those are the approximate numbers that we're going to use just for illustration purposes. And I want to start by saying that I congratulate you for coming to this webinar because you are trying to learn about proper billing and coding for bronchoscopy, something that you shouldn't be ashamed of. Physicians are terrible about, caring about conducting their business. This is service. The health services you are offering to your patient, and you're just making sure that you're actually doing the paperwork so you can be reimbursed correctly and fairly. So I will start with some background, and I don't want to depress you, and I don't want you to take Prozac, but we are sort of in the era of decline over the last 2 decades, and our expenses are rising in healthcare, and our professional fees, unfortunately, are falling as private payers seek to mimic Medicare and drop our reimbursement. So I guess we still are paid nicely as physicians, but the reimbursement rates have dropped significantly in the last 2 decades or so. And just as an example, I didn't have one on bronchoscopy, but on another popular procedure that we do as pulmonologists and interventional pulmonologists, if you can see insertion of chest tube, how the reimbursement value changed over the years. In 1995, you would be paid by Medicare approximately $300. You can see the progression of it, and by 2002, it was $210. So there's no doubt that the reimbursement has gone down, and it's really important then to make sure that we do it right and we do it fairly, compliantly, and get paid for what we do. So I want to start with some basics, and some of you might know this, some may not, but it'll be just a quick review on some concepts and acronyms, and then we'll go more into the depth of it. But CPT basics. What is CPT? This is an acronym for Current Procedural Terminology. Really, it's just a listing of descriptive terms and codes for physician services. And actually, it was not the government who created it. It was the AMA, the American Medical Association. They wanted to develop a uniform language so people or the payers and the physicians' offices and the hospitals can actually have a conversation about what was done for the patient and what should be paid. So it's just really a language to conduct that information. CPT is organized actually in these sort of 5-digit categories. So, we're in the respiratory, so a lot of our code starts with the 3 because we're in this 30,000 category. Radiology is in the 7, and if you do ultrasound guided chest tube or thoracentesis, some of the ultrasound code starts with the 7, and then a variety of things as you see here. So again, organized in these kind of number category, and we fall into the 3s as you see. It's very important to remember, and not everybody knows that when you do a procedure, actually, let's say a bronchoscopy with BAL, there are actually 2 fees. One is professional. That's your actual work. That's what you get paid by the payer for your labor. And then there's another chunk of money that goes to whoever owns that facility. In bronchoscopy, it's typically the hospital. There's not that many independent bronchoscopy facilities, so the hospital usually owns these facilities, and the hospital then will get the technical fee, which is a different amount of money, and that's supposed to cover the technical costs of the procedure, from sedation to nursing to the room, and so forth. And it's interesting, the way Medicare pays us, actually nothing is fixed. They use this fancy formula, and you don't need to know all these variables, but I'm just going to briefly go over them. There's something called resource-based relative value scale, and that just assigns a value to each CPT code based on the amount of work, practice expenses, liability insurance, and then geographical practice cost index. So they actually take into account where you practice. So that number is different if you practice in New York City versus if you practice in a small town in Mississippi. And then there's this money conversion factor, which is really just a value used in the Medicare payment formula that turns RVUs into dollars. So just to show you how this formula looks like, this is the reimbursement formula. They take the work RVU for your bronchoscopy, let's say it's 4 times this GPCI, times the practice expenses, times CF, and that turns this whole thing into actual amount of money that you get paid. This conversion factor varies. I think in 2016 it was like $35 multiplied by all these numbers to give you that amount of money you get paid for bronchoscopy. So I want to review some of these codes, not that you have to memorize them, but surprisingly, a lot of pulmonologists don't know the entire set of codes for bronchoscopy. So if you actually do a bronch through a trach, that's a different code, different than if you go through the mouth or the endotracheal tube. So you can see here the first one, if you just do an airway exam through a trach, that's the code you would use. And then obviously there's just the 31622, one of the most common codes, or the base code. This is just an airway exam. And then now we start seeing some sampling, brushing, DAL, endobronchial biopsy, transbronchial biopsy, transbronchial needle aspiration. I highlighted the last 2 because you need to know that There's a code for additional biopsy for TBNA and transbronchial lung biopsy, meaning if you do a biopsy in the right lower lobe and then you do a biopsy in the right middle lobe, you've biopsied two-lobe transbronchial lung biopsy. So you build the first lobe with the first code, 31628, and then the second lobe, if you biopsy with this additional biopsy, 31632. Same for TBNA. This is without EBUS. If you do multiple nodes, you can put the first code, 31629, in and add additional biopsies. And then this is more sort of interventional code. So bronchial dilation, tracheal stent, balloon occlusion, foreign body, and then placement of a stent, an additional bronchial stent. So if you stented 2 bronchi, you can actually put both codes. Revision of stent, meaning that you adjusted the stent or removed it. Tumor removal, like mechanical excision, and then any blockage treatment with things other than mechanical resection, like laser, electrocautery, cryotherapy. The top code on this slide is actually for brachytherapy. Not many of us are doing brachytherapy anymore. And then the next 2 codes I highlighted because they're important to learn about. So, bronchoscopy with therapeutic aspiration of the tracheobronchial tree, initial and the subsequent. So these are codes meant to be used when you have a patient with a lot of thick secretions. You actually spent time to remove those mucus plugs. You should use this code. If it's initial or if it's subsequent, use the second code. This is an additional reimbursement over airway exam. So of course you can't abuse this code. The patient has to really have mucus plugs and things that you worked on to remove, so then use those appropriate codes. If you didn't know it, we do have a code for bronchial valves. These are the codes for the valves used in persistent air leak, not for emphysema. There are codes for putting them, for removing them, for additional lobe. And then finally, the last code is for doing injecting contrast in the airways, or bronchogram, which I don't think anybody's doing anymore. A few things that I always get asked about for navigation bronchoscopy. What do I code for? You always code the procedure that you did, biopsy, brushing, BAL, and then you can code this bronch with computer-assisted image-guided navigation. This accounts for the preparation navigation part. And of course, if you put fiducial markers, then that's the code that would take over 32999. Bronchial thermoplasty had codes created for it a few years ago, either 1 lobe or 2 or more lobes. And then now the codes are the most common that we've spent some time on is EBUS, obviously. So in 2016, we had a major update on those EBUS codes. Prior to that, we would use just TBNA 31629 and add this add-on code 31620. That was deleted in 2016, and it was decided that those now are bundled, meaning the TBNA, when it's done with EBUS, it's bundled into one code. You see the 3 codes that were created in 2016, 31652, if you sample lymph nodes with EBUS, 1 or 2 lymph nodes. If you do 3 or more lymph nodes, then you choose this next code, 31653, and you can see that has more RVU than the 2 lymph nodes and more payment. And then finally, there's a code for radial EBUS, and this is an add-on code, and I'll explain that in a little bit. So that you added to transbronchial lung biopsy, or brushing of a lung mass, peripheral lung mass, or lung nodule. So the top 2 are bundled for EBUS TBNA. The third bottom one is really for radial EBUS as an add-on. All right, moderate sedation was yet another change in 2017. In the past, before 2017, if you did a bronchoscopy with moderate sedation, the moderate sedation was bundled into the billing code of the procedure. We didn't record them, we didn't report them. As of January 2017, moderate sedation was separated from bronchoscopy, and it became a separate code. So there's 2 scenarios now for sedation with bronchoscopy today. If you're doing your bronchoscopy and using anesthesia service for your sedation, you will not bill for sedation as a pulmonologist. The anesthesiologist will, and your bronchoscopy, your RVUs, will have a deduction of 0.25 RVU. Not a huge amount, but some amount. If you're doing the moderate sedation, you actually then can bill it, but you have to bill it with separate codes than the bronchoscopy, and I'll show you that on the next slide. So those are the moderate sedation codes, 99152 for the first 15 minutes, and 99153 for each additional 15 minutes after the first 15 minutes. Notice there's a threshold to hit that, to bill that code. So for the first 15 minutes, you have to hit at least 10 minutes of sedation, meaning if you did one of those super fast bronchoscopy, if a quick airway exam and you did it in 3 minutes and sedation took 5 minutes, you actually cannot bill for moderate sedation. And same for subsequent segments of sedation, it has to be at least 8 minutes extra so you can bill for it. And I'll show you an example here coming up. Caveats to learn about moderate sedation billing. It's really all about intra-service time, meaning that the sedation is given by the nurse, but you're there during the service of sedation, and you're there face-to-face with the patient. And when the sedation is over and your personal contact with the patient ends, and that's that period of time that we're talking about. It has to be documented, that you were there intra-procedure, that what is the total moderate sedation time in minutes that would generate those codes, initial or subsequent, and you attest that the patient was monitored one-to-one and you were there. Again, the nurse can give the drug. You don't have to give the drug, but you have to be present when the sedation is taking place. Here's a good example to explain all of this. You just finished a flexible bronchoscopy on a patient with a right lung mass and mediastinal adenopathy. You performed EBIS TBNA on 4L lymph nodes and got the diagnosis of adenocarcinoma. You asked the nurse to record that sedation time, and she told you it was 49 minutes. It started at 1 p.m., this is moderate sedation, and finished at 1:49. So you documented this. You were there since in that time for the moderate sedation. And here's what you can bill for this bronchoscopy. You're going to bill your 31652. That's the EBIS TBNA of 1 to 2 lymph nodes. And then your moderate sedation, you bill for the first 15 minutes, and then the second 15 minutes, and the third 15 minutes. But you cannot bill the last 4 minutes of moderate sedation because that did not meet that threshold of 8 minutes. By the way, those subsequent moderate sedation codes really don't give you any more money or reimbursement, but they have some technical values for the institution, but they do not. You only get paid for the first 15 minutes. Just to give you an example, people always ask me, how much approximately is the payment for bronchoscopy for the work we do? Now, again, it's different from state to state, from year to year. I'm using here an example from Georgia, just a state that we picked in 2012. I haven't updated it, but I can tell you that it hasn't changed too much. But here's an example, just to give you sort of a feeling of the amount of reimbursement we get for the procedures we do. So, and comparing it to other things, so you can have a reference point. So if you do a high-level H&P, you get about $195. Remember that Medicare eliminated consults in the clinic. So now you either have new patient or established patient. If you have a high-level established patient, you get about $100. Critical care still pays handsomely, and that's why a lot of people like to do critical care still. So for the critical care, that first 35 minutes or so, you get $271 approximately. Now let's look at bronchoscopy. If you just do an airway exam, that's $147 approximately. If you do a TBNA, that's $205. BAL is a little over the diagnostic bronch, $148. And just a comparison to other sort of more expensive procedures, IVC filter by radiologists, they actually don't get paid that much more, $240. And pacemaker by cardiology is $357. Reimbursement for cardiology has also dropped significantly, so you see that across specialties, not just pulmonary. And how about interventional therapeutic bronchoscopy? A little bit more payment, but not tremendously more. You put a stent, bronchial stent, about $226. Again, these are Medicare rates, approximate Medicare rates. You put an additional stent, you get $76. Notice that revision of stent or removal of stent is actually pays more than placement of stent. The assumption there that removal of stent can be difficult. And then tumor removal by forceps mechanical resection is $261. Same if you do laser or cryotherapy. And then tracheostomy, actually, if you're an interventional pulmonologist or intensivist that does tracheostomy, actually has a higher reimbursement than all these procedures. And this is just, again, a little bit more reference points for you. Actually, pleural procedures reimburse well for the most part. Chest tube, now it can be an open or no imaging or with imaging, and you can see it's about $166. Thoracentesis is in the $89 to $112. So just kind of giving you an idea of the reimbursement rate. Again, those are approximate Medicare rate. Note that private insurance, private payers have different rates, and you're usually higher than Medicare. Those are not published rates. Those are negotiated rates between your practice, your hospital, and the private insurance company. So we can't cite those. We can cite Medicare. All right. This is really when we get into the thick of it. This is the section of the this talk that gets a little technical, but it's really important to understand on your part, because you need to understand how your procedure is built. So there's something called the multiple endoscopy rule. So you typically do a bronchoscopy and do multiple things. You don't just do a BAL. Let's say you're trying to diagnose a mass. You might do a BAL, you might do brushing, you might do a transbronchial lung biopsy. Well, if you do them all separately, in a separate procedure, biopsy alone or BAL, you'll be paid for each one of them fully. But if they're all together in one session, the payer is not going to pay you all of these procedures fully. So then only one CPT code is considered primary and is fully paid, and the others are considered secondary and they receive partial payment. And I'm going to show you examples on how that works. The partial payment works as follows. The payers say airway exam, that CPT code 31622 is the base code. And when we pay you a partial payment, we're going to take that secondary, tertiary code, and we'll subtract the amount of reimbursement for the base code, and what's left over is yours. So I'll show you an example. That will become clear in the next slide. All right, so this is just another way of looking at it. Primary procedure will get paid at 100%. Second, third procedure are not paid at 100%. They're partially paid, and they're paid based on what they would be usually paid minus the base code. And then add-on code gets paid at 100%, and I'll explain that in a little bit. So here's an example. You're bronching a 65-year-old man with a right upper lobe mass. You do a BAL, brushing, and transbronchial lung biopsy. So the transbronchial lung biopsy is the most complex and highest reimbursed, so that gets paid fully, $189. Next is a brushing. Well, if you had done the brush on its own and just in one session, the payment is $155. But brushing in this procedure is secondary, so we're going to subtract the base code, which is airway exam, which is $149. So you're going to get $6.25 for brushing. For BAL, again, if it was done alone, you would get $150 or so, but because it's a secondary procedure, it's going to be subtracted from the base code, airway exam $149, so you get a 96 cents for it. So a total would be $196.93. Again, these numbers are approximate and are used for illustration. Note that when you do biopsy, brushing, BAL, you cannot put the code for airway examination anymore. That's built into the other more advanced codes. So only the sampling codes now are reported. You cannot report the airway exam code, even if you did an airway exam. So what are add-on codes? Add-on codes are CPT codes that are not subject to the multiple endoscopy rules. They're fully paid on top of the other primary and secondary codes. However, their reimbursement is much slower. Examples are 31654 or radial EBUS, when you use it to guide sampling of peripheral lung lesions, or that 31627, the code we said you can use with navigation. That's the computer-assisted image-guided navigation. So here's an example we just used, that upper lobe mass that you did BAL brushing and transbronchial lung biopsy. Let's say you use radial EBUS to guide your transbronchial lung biopsy. Same thing's going to happen. You're going to be paid fully for the transbronchial lung biopsy. The brush and BAL will be subtracted, that base code fee, and so you're going to get very reduced amount of reimbursement. Notice that the radial EBUS code is paid fully, but it's not a lot of reimbursement. It's just $70. So you add it to the total here, and it will be $266. So add-on code, those are sort of adjuvant codes, or codes that help you to do what you need to do, are paid fully at a lower rate. All right, I want to talk a little bit about modifiers and coding. That's sort of a concept that's sometimes difficult for physicians to understand. So in the coding world, a service or procedure can be further described by using a 2-digit CPT modifier. Why? Why do we need a modifier? We're trying to convey some information to the payer about the procedure we just did. So the payer can understand what we did and doesn't make assumptions about what we did. And so there's various circumstances where these modifiers convey very important information. I'm going to show you some examples that are relevant to bronchoscopy. Usually, actually, in your practice, a coder will do them. You do your bronchoscopy procedure, you do multiple procedures and things, and they kind of read your report and do them. So you may say, well, I don't want to worry about it. But actually, it's very important to understand how modifiers work, so you can be empowered and know how the billing in your practice is going. So common ones I'm going to discuss are these 4. I'll spend some time on the top one, 25, separate E&M with a procedure, 53, discontinued procedure, and 59, separate procedures. I won't discuss the last one, 76, but it's important to know. It's rare. So repeat procedure, same MD on the same day, same 24-hour period. So let's say you got called by the ICU in the morning for hemoptysis. You went and did an airway exam and isolated the bleeding to the right middle lobe, and the day went on, but they call you back at 6 p.m. because the patient has yet another bout of bleeding and they really need you to come and clean up the blood or remove the clot. So if you do the second bronchoscopy that day and you don't put that modifier 76, or your coder doesn't, the insurance company will assume that it's a duplicate, it's an error, that your office staff just sent to request to reimburse the same procedure. So by putting that modifier, you're telling them, no, that's the same procedure. I repeated it. It's me. I did it the same day. And in documentation, you actually mention why you had to repeat the bronchoscopy. But the next 3 slides, I'm going to focus on those top 3 because they're more common and slightly more complex. The one that you really have to know is modifier 25. This is a very common scenario, and if you're using electronic health records, you actually are supposed to do it. The coder can do it behind you, but if you do it, you protect your revenue. So modifier 25 means that I, as a physician, saw the patient, did my E&M, my evaluation and management, and then decided based on that evaluation and management that the patient needs a procedure, and then I did it in the same day, the same period, that same 24 hours. So this is a common scenario. You're doing consultation in the hospital, and they call you to see a patient in the morning with lung mass, and the patient's MPO, and you see the patient, you decide he really needs a biopsy, and I'm going to do it today, I have time in the afternoon. So if you do not put modifier 25 on, this is actually is placed on the E&M, on the consult note, not on the bronchoscopy. If you don't put it, the insurance company, the payer will assume, well, that was just part of your pre-op evaluation, part of your sort of preoperative health and physical exam. It was not a separate consultation that led to the decision to perform bronchoscopy, and they will not pay you for your consult. So if you're using Epic, for instance, when I do this, when I'm on the consult service, if I do the bronchoscopy in the consult on the same day, I make sure when I bill my consult in Epic that I make sure that I add that modifier 25. I'll show you an example how this would be very detrimental to coding and billing. So here's a 64-year-old man that they called you in the hospital to see hemoptysis, chest mass, and you do a consult. You feel like it's urgent to do the bronch, and you're going to do it that same day, and you go ahead and do it. Well, you did not know about modifier 25, so you put your consult in and you submit the code through Epic, and you put your brushing, BAL, and endobronchial lung biopsy. See what happens here? The payer, because there's no modifier 25, denies the consult. It considers it part of the preoperative assessment, and then pays you. Remember the multiple endoscopy rule? Brushing got paid first, and then BAL and endobronchial biopsy got paid as that reduced rate when the base code is or deducted from the total amount. So you got a total of $183. Notice now what happens on the next slide if you actually do it correctly. If you attach the 25 modifier when you submit your Epic, your consult on Epic, you got paid for that. And notice the order here also. The biopsy was the highest reimbursed procedure, so that comes first and get paid as primary. Then brusher and BAL get to be secondary and tertiary. And look at the difference in reimbursement when you do the modifier 25, $139. Modifier 53 actually is very important to know because we all run into it every once in a while. It's discontinued procedure, meaning it's used to describe a procedure that is stopped or halted prior to completion because of an unexpected event or some circumstances. So, you started a bronch, you put the scope through, you numb the cords, and then hell breaks loose. Patient is agitated. You cannot really go past the upper trachea, or the blood pressure goes down or up, and you decide to halt that procedure. Many of us, if you don't know this modifier, actually would just say, forget it, I don't do anything. I'm not going to put a report or bill. But actually, you can bill it, and you can put your report and describe what you did. You have to document it very well. You have to say, what you did, how you prepared the patient, you did anesthesia, and whether it's moderate, local, and you inserted your scope, but then it was discontinued, and what's the reason. And actually, you will get reimbursed for this. It varies based on the insurance and the payer, but it could be paid up to 50% of reimbursement. So this is not to neglect. I think if you tried something and you were sincere and honest about it, that you did it and tried and started the procedure but couldn't complete it, this modifier is important to know. And lastly, this modifier 59, distinct procedural service. So this is applied in bronchoscopy when you do biopsies. So if you do biopsies, transbronchial and endobronchial on the same lobe, actually they will not let you bill the endobronchial biopsy. You will just do the transbronchial lung biopsy because it's considered sort of one procedure. However, what if the patient had two lesions, like in this picture? He had a left upper lobe mass, and when you did the airway exam, actually there was a endobronchial lesion in the right middle lobe. So these are two different locations, two different sites of sampling. So if that's the case, if you don't do modifier 59 on the second procedure, the endobronchial biopsy, it will not be paid. But if you put it, you're saying, hey, I did transbronchial in the left upper lobe, and I did endobronchial in the right middle lobe. That's why the 59 is attached to the right middle lobe endobronchial biopsy. Be careful, though, you have to put this in your note, that the site of the transbronchial lung biopsy was different than the site of the endobronchial biopsy, and be very clear about it. This is an area of scrutiny by payers, so talk to your business manager, revenue manager, but it's something that you should know about. And then I'm going to end up with two frustrating scenarios that I hear about from a lot of people. And I'll have the answer for you, which is probably not going to make you happy. But you performed the bronchoscopy in a patient with borderline enlarged hilar and mediastinal lymphadenopathy. You did your job. You put the EBIS scope. You inspected all the lymph nodes. And guess what? There was no lymph nodes to be sampled. All of them, like this picture, was small, less than 5 centimeters, and you did not sample any lymph nodes. Can I bill for EBIS? The answer is no. Unfortunately, EBIS is bundled, as I mentioned, so it's bundled with the TBNA, so you cannot bill that 31652 because you did not sample any lymph node. There is no code today just for linear EBIS. And so all you have to do is bill for airway examination. That's frustrating, and people get frustrated because I spent 20 minutes looking at lymph nodes. Unfortunately, if you didn't sample any lymph node, there's no payment for that. You'll just have to bill for airway examination. The next one is about therapeutic bronchoscopy. We often see a mass in a bronchus, like this patient, the right main stem bronchus mass here. So we do two things. We use heat therapy, electrocautery, laser, APC, to coagulate, and then we start maybe digging at it with forceps or something else. So you'd think you can bill both codes, right? The tumor removal, kind of mechanical debridement, and then the destruction of tumor with methods other than excision, laser, electrocautery, APC, etc. Unfortunately, you cannot bill these two codes together. They're bundled, and you must choose one of them. Usually you choose the 31641 because it pays slightly better. And so it's frustrating. You say, well, I did both, and I dug at the tumor and I coagulated it, but you only get paid for one of those because they're bundled. And I think we're coming to the end of this talk. I just want to summarize the major points, and then I'll open it for discussion and questions. So the point of this talk is to make you aware of the billing and coding rules. You have to understand the multiple endoscopy rules because you only get paid fully for one code, the primary code, and the others are paid partially based on the rule that I showed you. Add-on codes are paid fully on top of the primary and secondary codes. You have to understand modifiers, specifically modifier 25. You can say, well, my coder will catch it, but they're humans and they don't catch everything. So if you're in the hospital and you're billing for a consult, you better attach that 25 modifier to your consult if you're doing the procedure the same day. And finally, I think knowledge is power. If you're in private practice or even in academic, I do it. I sit with my billing manager or business manager and I look at my billing report quarterly or monthly, and I say, let's look at my denials, let's look at my professional fees for consults, for procedures, and if something's not making sense, then you know how to look into it a little bit and say, why are my inpatient consults not being paid for? Maybe nobody's putting the modifier 25 because you know approximately how many inpatient consults you did last month. Maybe you did 10 or 15, but if you see 2 being paid, then that's a problem. If you see that the codes that are not being paid or paid in bronchoscopy, that you're doing that BAL is the most common procedure you do, or your EBIS is not being paid for. I think all these are things that you start to understand when you learn all these coding and billing rules. And then I'll just end with a little light note. There's sometimes things that we don't have codes for, like this guy that the physician said, your insurance just called, they don't cover having a bad day. There's no code for it. There are things that we do that there are no codes that capture fully. For instance, injection of steroids or things that you inject in the airway. There's no code for that. So there's some stuff that there are no codes for, but we continue, obviously, lobby for things like that and try to get new codes. So there's a process to lobby the RUC committee and other CPT committee to get new codes, new RVU value. So with that, I'm going to end exactly at 40 minutes as I was instructed. And we'll open it for questions. So please feel free to type your questions, and I'll let David and Ara moderate this section and see what questions people have.
Great, Dr. Wahidi. Thank you for an excellent talk. Obviously, really relevant for today's practice. I'll get the questions going while we wait for the audience to come up with a few. You very eloquently reviewed the basic process of how the AMA and the CMS contribute to setting the CPT reimbursement schedules. And you also showed how reimbursements have consistently declined over the last few years, unfortunately. How might the pulmonology and IP community, including the ACCP and AABIP, how might these entities influence this process?
Yeah, that's a great question. So we do actually have some venues to do that. So both actually the ATS is a little more involved than ACCP, has representations on the RUC committee, and also initiate requests to consider new codes. So I think you'll soon get a request to fill out surveys about trying to get a new code, as I said, for injection of medication into the airway. And also every once in a while there's a re-evaluation of how many RVUs does this code or these bunch of codes deserve, because obviously the RVU, as you saw in that formula, dictate how much money we get. So your national organization do that work for us. The most important thing you can do is they often send surveys, and they ask you about valuation of these CPT codes, whether they're new or existing, and they're kind of annoying surveys because they try to compare them to things you do today, like they would compare a bronchoscopy CPT code to like a chest tube or evaluation and management. But it's so important to fill those out and be truthful about the effort and time involved in those, so we can get better reimbursement.
Great. It's good to hear those surveys actually do serve a purpose. We do have a question here. It asks if essentially the role for the 25 modifier for outpatient bronchoscopy, whether that's advanced diagnostic or otherwise.
So it's a little different in the outpatient because I guess you would see the patient in your clinic, I would assume, and you do the procedure the same day. I think that's the scenario. I think it also applies. So when you bill your E&M code from clinic, let's say at clinic in the morning you saw a new patient, and then in the afternoon you have procedure. So you would also amend that 25 to the outpatient consult. It does affect both inpatient and outpatient.
Just to tag on to that, I actually also had a question about the 25 modifier. Going back to your example, why does and maybe perhaps I didn't catch it, but why does the modifier attachment to the E&M visit dictate which procedure is assigned the primary code? So for instance, in your example, you had mentioned that the endobronchial biopsy was prioritized once the 25 modifier was added. Why is that?
Yeah, sorry, I wasn't clear about that. No, you're absolutely right. The 25 modifier has nothing to do with that. I was trying to illustrate two bad practices or two things that were not done correctly. I should have been more explicit. So that example, the 25 modifier not being there, led to that consult reimbursement being thrown out. The second point, which I didn't clarify very well, when the multiple endoscopy rule, again, we said the primary procedure gets paid fully, and then the other procedures get partially paid. So it actually makes sense then that the primary procedure should be the highest paid procedure. So A transbronchial biopsy pays more than endobronchial biopsy, more than brushing, more than BAL. So that's the right order. The example was showing that somebody didn't put the right order for procedure, and I think they put like BAL first. That got paid fully, but that's not the highest paid procedure. That's usually done by your coder, or if you use softwares like Provation or others that do your documentation for bronchoscopy, it actually automatically orders these procedures by the highest RVU and highest reimbursement. So that's a good question. I should have been more clear.
Excellent. Thank you, Dr. Wahidi. Any other questions from the audience? You can give another 20 or 30 seconds here, give our audience.
So we have a couple of other questions. So we have one that asks, can you bill for an unusually prolonged procedure, and can you bill for time?
So yes, and I did not put that code, modifier. There is a modifier 22, which actually denotes that it was a very difficult procedure. Increased procedural service, it's called. The problem with that, the reason I didn't highlight it, it's payers really scrutinize that one because you have to really have had an unusually difficult or time-consuming procedure. Meaning, let's say, I don't know, you went there to do biopsy, and then there's bleeding and clot, and that procedure took you 3 hours, and it was extremely difficult. Then you can say, you can document very well why it was difficult, why it was time-consuming, and then attach that 22 modifier. And I can tell you that's a little more scrutinized and doesn't always get paid, but if you truly feel that the procedure took, triple the amount of time or effort that you usually do, then you can use it.
Great. Thank you, Momen. We have another question asking if you have a recommendation on a resource that you would recommend for people to use for billing and coding.
Yeah, so there's not a ton of resources. The ACCP publishes a yearly book on CPT. I mean, it's really a listing of the CPT codes in the entire field of pulmonary, from sleep to ICU. It's really a little more advanced, but it's very good if you manage your practice or, your solo practice or something and you're really involved in billing. It has a lot more details. But other than that, actually, there's really great articles in CHEST every year or so. There's this series, Practice, I think something about management of practice or something like that, the name of the series. And they publish every 6 months or so something about the billing and coding. The other thing, the ATS has a quarterly billing and coding newsletter. Subscribe to that. It really keeps you up to date. It's about 4 or 5 pages. It comes every quarter, has really good tips on billing and coding.
Looks like there's one more question here, Doctor, or a couple more questions here. Dr. Wahidi, do you bill for thoracic ultrasound, for example, when you're evaluating effusions, if a thoracentesis or chest tube ultimately is or is not required?
So, as you know, that the thoracentesis now with ultrasound is bundled. So if you do an ultrasound with thoracentesis with ultrasound, there's a bundled code, and if you do it with no ultrasound, there's a different code. However, I think what you're asking for is, what if I bring a patient for thoracentesis, ultrasound guided thoracentesis, I look and there's not enough fluid to do anything. It's just a small effusion. You can actually bill this code 76604, which is basically ultrasound of the chest. And you have to write in your note that you did an ultrasound, it was a small effusion, you describe it and say not enough fluid to perform thoracentesis, and that becomes just an ultrasound code of 76604, not a thoracentesis code.
Great, thank you. We have a question here asking if you were aware of any changes in the endobronchial valve placement CPT Apparently, the question asker has got some different information from their rep.
I don't think so. I do not believe the CPT code for placement of valves. I don't think they've changed. I will look again. I think those have been the same codes since they've created them, but I'll look again and I'll send a follow-up. I believe those are the codes, and I'm looking actually online here, and it still says the same. I'll be interested. Maybe that the person on who asked the question can send me an email, and I'll double check it.
Okay. One final question, it looks like, or a couple more actually. Can we bill for a bronchoscopy while doing the perc trach? Presumably the guidance for the perc trach with a modifier, or is it a separate bill?
Unfortunately not. Bronchoscopy, when it's used to guide the perc trach, is bundled with the procedure, and you cannot bill for it. However, one exception, and it has to be truthful, that sometimes you actually do perform a bronchoscopy for the trach to clean up mucus plugs from somebody with, horrible mucus plugging. If you do that and report that therapeutic aspiration, and then use the same scope to do the perc trach, you can possibly bill for both. But it has to be clear that it was for clearance of the airway, and has to be truthful, because just guidance of a perc trach by a bronchoscope is actually bundled in the procedure, and it's not allowed to be billed.
Okay, this final question is asking about adding the 76604 code, which I believe you said was the ultrasound code, to a thoracentesis or chest tube placement. No, because again, that code, I believe the 32555, it's not in front of me, but that code is bundled usually. So if you do thoracentesis with with an ultrasound, that's bundled. If you do it without ultrasound, there's a code for without ultrasound. The code I told you about is purely for just an ultrasound. There's no procedure with it. We have a quick follow-up by Dr. Argento about the previous question. Sometimes before the perc trach, a BAL is performed. Can you then bill separately for the BAL and perc trach?
Again, I think just like the clearance of mucus plugs, if it's truthfully an indicated, procedure, and you document it, you can actually bill for it. But it has to be, you can't make it a habit. Just say, I'm going to do a little quick BAL anytime I do bronchoscopy with the perc trach so I can bill for it. Because that, quickly will become a pattern, and it's not truthful. If it's truly every once in a while you do a BAL and it's indicated, and you just happen to do it before the perc trach, then you can bill for it. Always check with your billing revenue manager to make sure that applies in your practice. But again, if it's indicated and truthful, the guidance that you may be able to bill it.
Excellent. Thank you, Dr. Wahidi. Any other final questions from the audience before we wrap up today?
While we're waiting for that, if I may chime in, Ara, I would like to alert the audience to the next upcoming webinar, which is tentatively scheduled for Thursday, May 3rd. That will be endobronchial ultrasound beyond the needle, so it'll be on specimen processing and handling by Dr. Roberto Casal and John Stewart from MD Anderson. And any last questions? Otherwise, I would really like to thank Dr. Wahidi for his time and expertise. I think this is probably one of the clearest and best delineated discussions that I've heard on coding and billing. And you may think I'm joking, but I'm going to ask all of my fellows to join the AABIP just to listen to this talk they will probably save the amount of money that you're gonna save them is going to more than overcome the cost of admission to the ABIP.
Great. Thank you all.
So with that, I will end the night, and thank you everyone.